welcome to all of you. My name is Mariangela Pellegrini. I'm the Educational and Patient Program Manager for the ERN-EuroBloodNet, and I'm really glad to welcome all of you on behalf of the GenoMed4All at the ERN-EuroBloodNet coordination team on this program dedicated to artificial intelligence in hematology for public at large. This program indeed has been conceived by the steering committee of GenoMed4All, and it is an European online interactive educational program, as said, on artificial intelligence and its application in hematology. And we aim with this program to increase awareness of these cutting-edge advances, of this growing role of artificial intelligence for the diagnosis, treatment, or follow-up of the application of these in the hematology and clinical domains. So the program, as you may know, consists of 4 webinars. Those are provided by key expert speakers in this field, so artificial intelligence and rare hematological disease. We had already a first webinar on the 3rd of September. It will be soon available on the YouTube channel. And we talk about on the program of GenoMed4All and the application of precision medicine in hematology as a general overview. But before arriving to today's lecture, I would like to share with you some home rules. So as you can see, this session is recorded because all the video will be available on the GenoMed4All and the ERN-EuroBloodNet website and the YouTube channel, the EuroBloodNet Edu channel, together with the presentation. So if you feel not comfortable with that, please switch off your camera, change your name in the Zoom platform, or please notify it to me and we'll take care of that. Said so, your microphone will be muted just at the end of the presentation. At the end of the 3 presentations today, we will have the Q&A. As you can see, we are sharing a QR code of Slido, that is a polling platform used for meeting events that gather questions, and you see the question displayed. So please do not hesitate to use the QR code or the link that is displayed for in sharing your comments, feedback, question. Every of them will be tackled at the end of the presentation. So we can arrive today at now at today's lecture. So we are going to talk about use case challenges, myelodysplastic syndromes, sickle cell disease, and multiple myeloma. With us today, we have 4 speakers. They are all members of the ERN-EuroBloodNet. So first, talking about MDS use challenge, there will be Professor Matteo Della Porta, Associate Professor of Hematology at Humanity University in Rozzano. Mar Manu Pereira, she's the head of Rare Anemia Disorder Research Laboratory in Valdebron Research Institute in Barcelona, and also the scientific director of the ERN-EuroBloodNet. Raffaella Colombati, a pediatric hematologist, oncologist at the Pediatric Hematology Oncology Unit in Padova, in Italy. And Marina Martello, a fixed-term researcher at the Institute of Hematology and Oncology Science in Bologna. So please, Matteo, the floor is yours. You go first with the use case of MDS. Thank you very much.
Thank you very much, Mariangela, and good morning to everyone. So my job today is to discuss on practical use of artificial intelligence in order to improve potentially the management of patients affected with MDS. So I will share the screen. So basically, why we decided to focus on myelodysplastic syndromes in order to develop artificial intelligence-based solution? And the answer is clinically driven, because we know from a clinical perspective that we are referring with a population of patients with a very heterogeneous disease in terms of biological and genomic background, as well as in terms of clinical outcomes. So we are facing with a rare disease with a very large clinical and biological heterogeneity, and this situation may significantly affect our capability to provide the right choice in terms of treatment of the patient and clinical management. So this will be one of the ideal scenarios in which artificial intelligence can improve our practical management for a specific disease. Just to introduce the scope of GenoMed4All, GenoMed4All is an European consortium based on the clinical expertise of EuroBloodNet, the reference European network for rare hematological diseases, together with some technological partners. And the aim of the project are basically two. The first one is to define artificial intelligence-based solution to improve personalized medicine in rare hematological diseases. And the second one is to develop a federated learning platform in order to improve the capability to share information, clinical and genomic data across different institutions. So during this presentation, we will focus on two different types of artificial intelligence. The so-called machine learning that refers to a sort of more traditional concept of artificial intelligence. And we know that machine learning is basically aimed to create a sort of more efficient systems and processes and analysis by reducing cost and human effort. And in the second part of the presentation, I will focus more deeply on a new vision for artificial intelligence, that is generative AI. This type of application of artificial intelligence refers to new technologies that are able to generate new evidence from available data. That means to create a not previously existing value. So in the context of GenoMed4All, we provided a strategic choice to develop AI solutions that are compliant with respect to the recommendation of WHO on the clinical implementation of AI technologies. So as you can see here, we were compliant in all our activities to three principal points. That is to develop transparent models. So we develop solutions that are fully explainable in terms of clinical value and patient communication. For each of the model, we provide an extensive validation for the model in order to check for the generalizability of the results. And finally, we provided some specific action in order to be compliant with the European regulation on data protection. So the first activity that we developed within GenoMed4All project was the creation of a framework based on both classical statistical methodologies and artificial intelligence techniques that address the most relevant clinical issues for MDS and more in general for rare cancer, that relies to provide an accurate classification of patients. So in facing with a very heterogeneous disease, we have to be able to define a group of individuals with some clinical and biological similarities within the same disease group. And as a second point, to address the issue of disease risk assessment. So to be able to capture prognostic information at individual patient level in order to drive clinical decision-making process. And as you can see here, we developed Mosaic, a multimodal framework based on artificial intelligence that include a large number of artificial intelligence-based methods to improve the capability to provide an efficient classification and prognostication for patients affected with rare diseases. So the first application of this technology was done in terms of disease classification. We know that in hematology and also in MDS, conventional classification systems based on clinical and morphological criteria are now complemented by introducing genomic and molecular features which are closer to the disease biology and may better capture clinical pathological entities. And for MDS, two new classifications have been recently released, in which the important point is that three different entities were characterized by the presence of a specific gene mutation. So despite these progresses, several key differences exist between the two classification systems, and this not harmonized classification of the patient may have a negative impact in the clinical management of the patient as well as in the design of clinical trials. So we try to address these already existing issues in the new classification for MDS by some specific activities. As a first point, we used conventional statistical methods in order to provide evidence for the capability to release a more broad molecular classification of MDS. That is a system in which all the patients were classified in a specific group defined according to specific molecular features. And as you can see here, we analyzed a large international database collected by GenoMed4All, including more than 2,000 MDS patients. The application of statistical methods provide evidence for the principle that MDS will be classified in several distinct subtypes according to specific genomic characteristics. So importantly, these subgroups do not correlate with morphological entities as defined by the currently available classifications. And all these groups display significantly different clinical phenotypes and outcome. So after this first study on feasibility for a molecular classification, we moved to use AI solutions in order to analyze the same population of 2,000 patients, by using these new technologies. And as you can see here, basically the use of artificial intelligence methods may improve the capability of statistical learning models to detect a group of patients with an homogeneous genomic profile, as demonstrated by the fact that by using these technologies, we were able to identify 14 different clusters versus only 7 detected by using conventional statistical methods. So basically, this means that artificial intelligence is more powerful and efficient in detecting similarities among a very heterogeneous population, such as myelodysplastic syndromes. Another interesting point of this analysis is that we had the opportunity to refine the definition of a very important subtype of patient that are currently defined as MDS with TP53 mutation. These patients are around 10% of the whole MDS population, and the presence of TP53 mutation is associated with a very aggressive clinical phenotype, high probability of leukemic evolution, and resistance to conventionally available treatment, including allogeneic stem cell transplantation. By using artificial intelligence in clustering patients according to biological similarities, we had the opportunity to identify an additional population of around 5 to 7% of the whole MDS population that present the same P53 dysfunction that we observed in patients carrying the P53 mutation, but in which no specific mutation in TP53 gene were detected. We provided additional biological experiments on CD34 bone marrow isolated cells in this patient, and we clearly demonstrated that the abnormalities of several pathways in bone marrow cells, such as RAS, RAF, MDM2, and others, can recapitulate the same aggressive clinical phenotype of TP53 mutations by alternative mechanisms. And importantly, also this patient without a specific mutation in TP53 gene displayed the same poor outcome as we observed in mutated patients, and the same capability to provide an escape from immune response that can provide an explanation for the aggressive clinical features and outcome for these individuals. So in terms of potential clinical application of artificial intelligence, this means that artificial intelligence can improve our capability to define similarities in terms of disease biology in a population of a very heterogeneous patient, such as in MDS, and to better define patients that can be treated in a more intensive way because of a specific cellular dysfunction. The second project that we carried out within GenoMed4All was to use the same framework of artificial intelligence methods in order to provide a sort of clinical harmonization between the two existing classification systems, with the aim to facilitate clinicians in the identification of the patient and in a better definition of the optimal treatment for each individual patient. And as you can see here, we were able to improve the population of patients within GenoMed4All consortium to 7,000 patients with MDS that represent a solid basis in order to apply artificial intelligence technologies. And we use the Mosaic platform in order to better clarify what is the definition of each individual subtypes for MDS, and to provide clinicians a sort of hierarchical order in terms of genomic abnormalities that should be evaluated in clinical practice in order to provide an accurate stratification of the patient. Another point that can be addressed by conventional machine learning approaches is the prognosis of the patient. We defined MDS as a very heterogeneous group of patients in which the prognosis, that is the clinical outcome of each individual person, can be extremely different from patient to patient. And in general, also in terms of prognostic systems, there is a shift currently from conventional tools based mainly on clinical hematological features to next generation prognostic tools that includes also molecular and genomic information. And as you can see here, the presence of recurrent genomic abnormalities in MDS are able to explain a large proportion of the patient prognosis. So this means that we need to improve the clinical implementation of a genomic screening for this patient in order to be able to capture more efficiently prognostic information and to drive our clinical decisions. In this context, recently a new prognostic model was proposed, IPSS molecular, that is able to integrate conventional hematological parameters together with cytogenetics. And as you can see here, somatic mutations on 31 genes that are related to MDS. And this score was found to be able to improve the prognostic stratification of the patient across all the clinical relevant endpoints. That is the probability of survival and the risk of leukemic transformation. So the clinical question is if artificial intelligence is able to improve the precision of these tools. So in order to check for this question, we implemented our Mosaic platform in order to test the efficiency of innovative methods in order to improve the capability to capture prognostic information in MDS patients. And as you can see here, with respect to the reference accuracy for a prognostic model provided by IPSS molecular, the use of AI-based methods can improve the capability to predict a clinical outcome of interest. So this means that in terms of prognostication of the patient, starting from the same features included in the currently available score, artificial intelligence can improve the accuracy of the model and the precision for the prediction of the survival and risk of leukemic evolution. So in the second part of this presentation, I will move on a possible application of the new generative AI technologies in order to facilitate clinical decision-making in patients with MDS. And we know that for this patient, the only potentially curative approach is allogeneic stem cell transplantation. And we know as well that due to a not negligible morbidity and mortality associated with this specific procedure, an accurate selection of candidate patient should be done. And one of the most critical points in order to define the risk-benefit profile for allogeneic stem cell transplantation at individual patient level is associated with the optimal timing for the procedure. Actually, the so-called revised IPSS, so a score that is mainly associated with conventional hematological features, represent the basis for transplantation decision-making process in MDS. And there is a general consensus, as you can see here, that in patients with high-risk disease, according to a revised IPSS, to perform transplantation immediately is associated with a gain of life expectancy. However, in patients associated with so-called low-risk disease, may provide a more difficult scenario in terms of optimal timing of transplantation, because we know very well that for many of these patients, the disease tends to be indolent without any risk of leukemic evolution for many years. So for a proportion of this patient, the immediate risk of morbidity and mortality associated with the transplant procedure could not be acceptable. So this means that in clinical practice, the definition of optimal timing of transplantation for patients with low-risk disease is a challenge, and some areas of uncertainty still affect clinical decision-making process. So for this, so in this context, we aim to try to use molecular information and a specific artificial intelligence technique in order to provide some more robust evidence to clinicians to define in a more appropriate way the optimal timing of transplantation, especially for those patients diagnosed in early disease. And as a first point, in the GenoMed4All, we had the opportunity to provide an independent validation for molecular IPSS. And as you can see here, for the first time, we observed that this score is also useful in order to stratify the probability of survival and the probability of disease relapse in those patients receiving allogeneic stem cell transplantation, thus suggesting that the clinical implementation of molecular IPSS can improve the capability to provide a more accurate selection of patient candidates to receive a transplant and to define in a more appropriate way the optimal timing of the procedure. In the GenoMed4All, also in collaboration with Politecnico di Milano, we therefore aimed to develop and to validate a clinical decision support system, that is the technology that can help clinicians to define the optimal timing of allogeneic stem cell transplantation for MDS based on clinical and genomic information as provided by molecular IPSS. We had the opportunity to analyze a retrospective population of more than 7,000 patients that were stratified into a training cohort and a validation cohort. And this is the methodological framework that we used. Just to, I will not enter into specific details of methodology, but just to mention that in order to help clinicians for a clinical decision, we set up a complex model in which we started for modeling the natural history of the disease, and then we shift to complex simulation analysis, also including artificial intelligence, that are a sort of randomized clinical trial in which each single patient defined by clinical information and risk according to molecular IPSS is randomized in different treatment policy, that is different timing of the transplant procedure, and the outcome in terms of life expectancy of these different policies is compared in order to define the best time to proceed with the transplantation for each individual patient with MDS. And just to have an idea for for the outcome of this decision support system, as you can see here, in the training cohort, we have a clear message from a clinical perspective that patients with low and moderate low risk disease, according to molecular IPSS, should be associated with a delayed transplantation policy. While for patients with moderate high, and very high risk, to perform transplantation immediately is associated with the best probability of life expectancy. And importantly, all these results were confirmed, as you can see here, in an independent validation population. So this example represents a simple application of artificial intelligence-based techniques in order to help clinicians to perform a very difficult clinical choice in a specific setting in which we have no evidence generated by randomized clinical trial. And overall, including molecular information in our transplantation decision-making process will change the transplantation policy in around 20% of the patients. And including IPSSM in clinical decisions resulted in a significant gain of life expectancy of the whole population that is eligible to a transplant with respect that the decision that is only based on conventional information. Again, this first application of artificial intelligence techniques can provide a clinical utility in assisting clinical doctors, medical doctors, in performing very difficult choices, especially in those scenarios in which we have no sufficient evidence coming from randomized clinical trial. So I will stop here. I think that message to take homes are basically two. The first one is that the clinical development of artificial intelligence solutions and their clinical implementation should be clinically driven. So we have very clear questions to be addressed by this technology. And the second point is that especially generative artificial intelligence can help to generate new evidence that can be useful in terms of clinical decision-making process to assist medical doctors when we have a lack of information from conventional clinical trials. Thank you very much for your attention.
Thank you very much, Matteo. So now we can pass to the second use case, so the one dedicated to sickle cell disease. So I invite Marmagnu Pereira and Raffaella Colombati to take the floor. Thank you very much.
Thank you, Mariangela. Can you see the slide?
Yes.
Yeah, okay, thank you. So, well, thank you very much. We'll present together with Raffaella and I, as anticipated by Mariangela. You will see that we are not so advanced as MDS, but we'll do our best to give you an overview of the situation of sickle cell disease in Europe and also what we plan to do in the GenoMed4All project. So I first give the floor to Raffaella, who will start.
Hello, everybody. So sickle cell disease is a genetic disease due to a point mutation, so to a very unique single mutation, as you can see in the balloon up here. And in spite of being due to a single point mutation, this gives rise to a series of different events that are the sickling of the red blood cell, the vaso-occlusion and limitation of the flow in the blood vessels, inflammation in the entire body, and then hemolysis and endothelial dysfunction. And you can see it in the picture even on the left side hand. So in spite of a single genetic mutation, many things, many different mechanisms occur in the body. And this next slide, please. Mar, I think you have, okay, thank you. And this gives rise to many different symptoms and many different signs and the involvement of many organs. And so we have both acute complication that you can see listed in red, in yellow, and chronic complication that you can see listed in green. And so it's a chronic disease with multi-system involvement. It has decreased life expectancy, and it translates in a lower quality of life since childhood. So what is difficult to understand is that in spite of a single genetic mutation, the phenotype, so the manifestations can be very different, and we still don't know why one patient develops some of them, why another one develops all of them, and why patients develop manifestation differently. The next one. And one of these examples is our involvement of the brain, what are called silent infarcts, because they are stroke, but the consequence is not a movement complication, but it's a problem in cognition, attention. And this happened since 1 year of age and have a significant morbidity because more than 25% of the children are affected by 6 years of age and 40% by the age of 18, with many consequences, as you can imagine, on schooling, working capacity. Moreover, we have barriers to identify and to screen in the real world setting because not all centers have experts. And moreover, we have a maturing and evolving brain from childhood to adulthood. And sometimes it's different to differentiate between biological lesions of a growing brain or a silent infarct. So pathophysiology, diagnostic, and risk factors or risk of progressions are incompletely understood. Next one. So as I said, we have a disease due to a single gene mutation with many different pathophysiological mechanisms, which we don't know how they happen differently in different people. And this is something we should know because now we have some treatments that address one or another of these mechanisms. So we have to choose which drug is the best for each patient. You can see in red the ones that are approved and available in Europe. Commercially available are hydroxyurea, of course, chronic transfusion, and recently in some European country, voxelotor. The other ones are still under investigations in some clinical trials. And so what we want to understand is why some patients develop a clinical phenotype and why others don't, which are the clinical phenotypes that we can classify and in order to have a personalized medicine. Next one, I think it's your turn, Mar.
Yes, thank you. Okay, so thank you, Rafaela. So what, as said by Rafaela, sickle is a monogenic disorder, but the clinical manifestation is very high. And we know so far that there are more than 800 genetic modifiers that could be impacting in this heterogeneity of the clinical picture. Then, as you saw in the second slide by Rafaela, there are many complex and interconnected physiopathological pathways, but we are not able to understand how this is translated into the different clinical outcomes that are impacting on the patient. There are all these new treatments, But actually, when we move to the laboratory, we don't have functional tests that are used or that are able to predict or to do a disease classification, to have prognosis markers for all these different clinical outcomes, as were mentioned by Rafaela, or to understand or to predict how will be the response of the patients to the different treatments. So we are lacking all this. And what we wanted through the GenoMed4All is to develop some AI-based scores that combining clinical data with research data, and we understand as research data, genomics, metabolomics, as we'll see, to predict the risk, the overall risk, but also the time of occurrence of some severe complications that the group of experts of sickle cell disease from the URN, we agreed on some key clinical outcomes as the recurrent vaso-occlusive crisis, acute chest syndrome, the silent infarct, stroke, renal impairment, hepatic failure, and retinopathy. But then, okay, that's fine, but all the power of the AI is there to be used for these objectives. But another challenge that we face is the lack of large amount of high quality clinical and research data in sickle cell disease. So we are starting from a very starting point, let's say, because we are lacking of these data sets. And why is this important? Also, Rafaela was mentioning the lack of expertise, for instance, to diagnose silent infarct. And this is also impacting on research. And I give you an example. So as you saw, we want to better understand the risk for a stroke in sickle cell disease. And we use a technique, a methodology that is the transcranial Doppler ultrasound to see how is the risk for a stroke in the patients. However, we understood through a survey that was conducted through the ERN that more than 70% of the patients with sickle cell disease are not correctly screened for understanding their risk for having a stroke. What does it mean for research? Not only for the clinical practice, that of course this is a very important outcome from this survey, but this also impact on the research. Why? Because if now we imagine that we want, and it's like this, that we want to combine genetic data, genetic modifiers with clinical data to understand which patients or which genetic modifiers are protecting or increasing the risk of the patient to have a stroke, we need to plan our research protocol in a way that through the analysis of these genetic modifiers, we divide our population between patients at risk and patients that are not at risk. But if this methodology for labeling the patients to be at risk or not is not well done from the clinical practice, there is no way to label correctly our patients. So when we want to correlate the genetic modifiers with the patients that are at risk or not for this very important clinical outcome, we are facing two situations. We face a first situation in which not all our patients has been screened. So we have less data than what we could have. And what is more important, if this screening procedure is not done correctly, some of the patients will be labeled as not to be at risk when they are actually at risk. And this means that we'll be including some confounding factors to our research study. So for this reason, for sickle cell disease, that is a very complex disease and is something that is also important to understand is that sickle cell disease has a ethnic origin or component, and So for this reason, this also impacts research, because it's not, as you may imagine, it's not the same having a genetic analysis for some ethnic populations or others, but also the distribution of the patients in Europe. So actually, very recently has been published a Lancet Commission with a group of experts that have worked on what would be needed to improve the clinical care and the research on sickle cell disease worldwide. And for this Lancet Commission from EuroBloodNet, we were requested to prepare a viewpoint on the situation of the disease in Europe. And for this, a group of experts from 12 EU member states that we have here, we prepared the landscape and the challenges that we were facing in Europe for advancing research for both the clinical practice, but also for advance in research in sickle cell disease. So what we understood is that after several analyses of the available data sets, we understood that the best figure that we can provide today in Europe is that probably we have something between 28,000 and almost 50,000 of patients affected with sickle cell disease in these 12 countries. As you can see, we don't have very accurate numbers. And why? Because we don't have registries of patients. So we are working on this, but this is the best that we can have now about an idea of the population in Europe. Also, what we understood through this analysis is that most of the patients, but most, as you can see here, for sickle cell disease is very important the neonatal screening, because it's a disease that can be early diagnosed in the newborn and then can be prevent for the more the first complications in the first childhood. So there is a programs for newborn screening, and we know, or we understood, that they are implemented in most of the countries, but more or less 330 million inhabitants will be screened out of 447 in the total European Union will be screened for sickle cell disease. And the average prevalence in birth is in the order of 1 out of 3,000. So you see that it's still being a rare disease, is a disease with a high impact on the population as in total in Europe. So what we are working in EuroBloodNet is to tackle the disease from different perspectives. It's important to understand that we need the centers of expertise. We need to work on these guidelines and best practices, because as I showed you before, if the guidelines are not well implemented, or there are no experts, as was also pointed out by Rafaela, we are at the end, we don't have good quality of data to advance in research in sickle cell disease. We are working on education, we are working on patient empowerment, and in this part, what is more for the topic for today, in patient registries, in order to have large amounts of good quality of data and the reuse of this data in the projects as in the GenoMed4All. So very rapidly for the registry, so what we are working is through the RADIP. The RADIP is the European Registry for Rare Anemia Disorders. What we are doing is we give the possibility to share and pull data on sickle cell disease in Europe. Through this, we can reach critical numbers, and this allows us to perform clinical trials or research projects, then generate knowledge, evidence, and at the end to translate these AI tools, in this case, to the clinical practice for the better healthcare of the patients. So how we are working for GenoMed4All? We started from our RADIP CRF for the epidemiology, and we expand this data set of data that we are gathering in the European registry to also incorporate different variables that were linked to our clinical outcomes in order to develop the AI algorithms for risk scores. So we have expanded from 200 parameters to more or less 400 parameters. We have different types of data on demographics, chronic organ damage, assessment of organ damage, all the acute complications, treatments of a spleen, laboratory data, and then also we need also to incorporate the research data because we gather through this all the clinical and standardize the clinical data, but also we need to standardize all the research data. And for this, we are using different ontologies for rare diseases, for laboratory tests, for treatments, and specifically for sickle cell disease. So what is our objective in the frame of GenoMed4All? As I told you before, so there were a lack of large data bases with both clinical and research data. So the EuroBloodNet partners agreed to have a target of 1,000 sickle cell disease patients and to generate and standardize these different types of data in order to merge them and then apply the AI methodologies as described by Matteo for sickle cell disease. So we want the different types of data are genetic modifiers because as was already explained, it's a monogenic disease, but it's very clear that there are some genetic modifiers directly impacting on the clinical picture. Then we also want to work on metabolomica because it was, as the first slide by Rafaela, okay, even if we better understood the genetic modifiers, there is all these different physiopathological pathways that is not really understood how they are combining in the different patients, why some patients have more kidney disease or liver or a stroke. And then metabolomics is a new way to understand at the end how all these different characteristics are like impacting on the metabolome and the different pathways in the disease. Then also we are working on rheology, and this is a different level to understand the disease. We want to understand here how the red blood cell, the behavior of the red blood cell for the different patients, and we do this in vitro, but then putting the red blood cell in different oxygen grades. So we force the cycling event in vitro, and then we are able to monitor the behavior of the red blood cell. And then also we are working with MRIs. This is for the specific objective on silent infarct. And as I told you before, we are merging all this data with the clinical data that has been collected and standardized through the RADIC registry. So I want to also show you who is doing all this effort, because this is being a huge effort, and the EuroBloodNet partners that are part of the GenoMed4All. So we have 4 countries contributing and several clinical sites, as you can see here, with this objective of gathering all this information for 1,000 patients. So we have 2 centers in France with Pablo Bartolucci and Marianne Montalemberg. Then my colleague Rafaela Colombati today are with me. For Italy, then I'm coordinating the effort in Spain, but also we have other centers participating from Spain with Elena Cela, Ana Ruiz, and Salvador Payan. And then we have in the Netherlands, Eduard van Beers, who is coordinating the effort from the Netherlands, also with a national network with Bart Villemont, Marion Nosen, and Saskia Skold. I think it's important to show you that in these 2 cases, we are also working on this national network. It's very important to understand that we are not able to work alone for sickle cell disease, but really we need to rely on this European, but also national networks. And I know that also for the specific aim of MRIs, Rafaela there are several Italian centers also contributing for this effort, and some from Barcelona and from France now. So it's really a collaborative effort. So then, what would be the specific objectives of the AI? So we wanted to understand or to allocate the sickle cell disease patients in different groups according to this genomic profile, according to the genetic modifiers. We want also to allocate, to do some clustering of these patients according to the metabolomic profiles. Then there is a specific objective for radiomics that Rafaela will explain a bit more. But at the end, we want to combine all this information to be able to predict some of these important clinical outcomes. And then, Rafael, if you want to go more in depth for the radiomics.
Yes. So the idea for the we want to develop a probability score for using AI-based brain MRI images analysis. And this will be utilized not only to diagnose already existing lesions, and this is a challenge because many algorithms that are produced in the AI field are used only, are valuable only if you have a single data set in which the images are collected with the same type of protocol and with the same type of machine. The challenge of our project, and which is successful, and we're finalizing the result, is that the algorithm can be used in real world with different machines, different type of MRI images that you are collecting, and nevertheless, it has a result. And then the second part of AIM-3 is to predict the risk of developing silent infarcts in the future by correlating all the clinical, metabolomics, genetic data, and functional data that Mar explained before, together with the MRI lesions in the brain.
Yeah, if you want to explain that one, Rafa, or me as well.
Okay, so what Mar said, and we explained in the previous slides, you can see that the objectives is 1,000 patients. We are almost reached that and are expanding more, and collect all the data that we said in previous slides. So you can see it here all in the same picture, and use AI models that include all the clinical variables and all the other variables in a way that we could have, we could define different clinical phenotypes in which we could use a personalized treatment. The next one. Okay, do you want to go on?
Yeah, well, it's the last one. So just to show you that also what is important for us is that all what we are doing, all this effort, can be then scaled up to other centers, because as you saw before, now we are working with 5 main centers in 4 countries. But of course, we want to do this effort, then expand it, and really to be translated into the clinical practice to all the other clinical sites. And then refine and improve all these models, incorporating new data sets. But and we wanted to do it something that is realistic. So based on the routine care and the routine variables that we can collect from our patients. And just to show you that these are all the centers that are in the EuroBloodNet. So in the next year, there will be the opportunity for all of them to be on board in the project, and then this will be part of the next educational program to give more details on how you can collaborate, but this is at the end the objective. So having something that really can impact on the community. So these are the number of clinical sites that are actually dealing with sickle cell disease in EuroBloodNet in Europe. And then just, the last message would be that really very aligned with what Matteo said before. We need data-driven solutions. We need, if we want to advance in research in these complex diseases, we really need data-driven solutions that pull standardized clinical data, because if it is not standardized, will not have good results and good algorithms. And we need to be able to pull also the research data and combine it. And this is crucial in order to advance research in sickle cell disease. So, and thanks to the efforts of GenoMed and the EuroBloodNet partners and the RADIP contributors for clinical data. Rafa, maybe if you want to add anything, and the patients, of course, that we have a very close collaboration with patients.
That's all, Mar.
Thank you very much to both of you, Rafael and Mar. So now we go to the last presentation. So with the Marina Martello on multiple myeloma. The floor is yours. Thank you.
Thank you, and good afternoon, everyone. So my job today is to speak about the last use case of GenoMed4All project that is on multiple myeloma. In today's presentation, we will see how clinics information and also biological information are very important, and in particular their connection through artificial intelligence method are very important in order to better understand this pathology that is multiple myeloma. So starting from a brief introduction, multiple myeloma is by name and by nature, since generally the disease is considered as multiple diseases due to its very high heterogeneity. The multiple myeloma is a plasma cell disease, so it is characterized by an uncontrolled proliferation of plasma cells that are terminally differentiated cells inside the bone marrow. But more recently, increasing attention have been postponed also outside the bone marrow, since these cells and also other circulating markers might disseminate and distribute the disease also in other districts different from the bone marrow. Is a disease that evolved through a multi-step evolution. Then it started from an asymptomatic condition that is called MGUS, a monoclonal gammopathy of undetermined significance, evolved to a prenoplastic condition that is called smoldering multiple myeloma, and then to multiple myeloma that is the diagnosed disease. That might lately in time diffuse outside the bone marrow in extramedullary disease. So as I tell you before, the disease distribution must be heterogeneous with the presence of multiple lytic lesion, and due to this disease characteristic, more recently the introduction of liquid biopsy, so the study of all these circulating markers such as circulating cell-free DNA, plasma cells, and those exosomes might be very useful in order to resume the entire heterogeneity. Over the last 50 years, as you can see from this graph, the multiple myeloma therapy has been changed profoundly, starting from the 1960s with the steroid-based therapy until these days, where with the introduction of the so-called cellular therapies with CAR-T therapies, the specific antibodies, and the monoclonal antibodies that have improved very rapidly also the survival of multiple myeloma patients. However, despite these significant advances in therapy, the natural clinical history of multiple myeloma showed an alternance of remission and relapse phases through its course. So the aim of multiple myeloma, the clinical aim of multiple myeloma is to reach a remission phase and maintain this status as long as possible. What does it mean? Remission concept in terms of biology and also clinic? The remission concept has evolved over the last years, and now the main goal of current therapies are to minimize the disease present at the nose in terms of quantity. So as you can see from this cartoon, and you imagine the disease as an iceberg, the goal of the therapy is to reduce as much as possible the quantity of the disease until a state that is called of MRD, minimal residual disease, that can be detected with several methods and define the state of remission of the patient. So the deeper and longer is the status of remission, the greater is the survival of the patient. Since this concept is very important for multiple myeloma clinicians, there is another very important concept that comes through the biology study. That is that it is important to reach this very low amount of disease through the therapy, but the patient, even if they reach this benefit status, might have very different biological condition, very different biology underlying their disease, as you can see from this image. So you can reduce the quantity of the disease, but you have to look also at the quality of the residual cells, since they have very different biology. So if we can introduce in a very simplified way the biology of the disease, we can know that the multiple myeloma biology might be resumed in a multi-level complexity, where there is a very high complexity, intratumor complexity, where tumor cells might be very different from each other. There is also an intertumor heterogeneity, where patients with the same diagnosis might have a very different disease. And also the disease might change during time, and as we can see before, also in space. It is essential to know the biology of the disease, not only through the study of the multiple myeloma clone, so through the study of plasma cell clone, but also by studying the surrounding microenvironment. This is particularly important because, as we probably know, in the more recent and the most efficacious therapy might target both the tumoral clone, but also some cells that reside in the surrounding microenvironment. But in the last 10 years, we know from different studies in the multiple myeloma fields that the genomic abnormalities are the most important and the most impactful on the survival of multiple myeloma patients. So we know that the study of the genomic abnormalities inside the cells, so on DNA of cells, is very important. What does it mean to study the genomic abnormalities? Genomic abnormalities are translocation, are copy number alteration, and also mutation that can be detected with several molecular biology methods. In particular, in the last decades, the molecular biology methods have been really improved, and most of the information of multiple myeloma genomics derived from the fish studies, but now we have high throughput methods such as next generation sequencing that have added a lot of information with respect to the previous techniques as fish. So how can we manage this very huge amount of data, and why they are so important? All these data are very important because, as you can see from this image, this is an image of one of the last study of multiple myeloma genomics. If we use these high throughput technologies, we can describe all the information, not one information at a time, but all the information derived from the genome of multiple myeloma patient. And we can see this information derived from a huge amount of patients. So if we can resume this information will, and all the iteration of the patient can be condensed in different patient subtype, and once we can identify this patient subtype, we can use this information for a more precise medicine. The current risk stratification system illustrated in this image are not very in this moment are very suboptimal, since use very low amount of data, not all the information that we know describe the biology of patient. As you can see, these are the current use stratification system, the ISS, revised ISS, and the one from International Myeloma Working Group, and they use only very few genomic information, such as translocation 414, deletion 70p, and so on. Therefore, in this moment, we know that there is a very urgent need to refine the definition of high-risk patient by include or better integrate a lot of information, both clinical, biological, and also from imaging techniques, in order to best refine and better predict the high-risk myeloma patient. To this aim, in the GenoMed4All project, we have in the multiple myeloma use case, we have enrolled 300 newly diagnosed multiple myeloma patients, and also we are using an external cohort of nearly 1,000 patients, newly diagnosed multiple myeloma, from a public repository that is called Compass. And with the final aim to, as I said before, to refine the definition of high-risk patient, possibly by identifying predictors of early relapse patient within the 18 months from diagnosis, based on the integration of baseline genomic, clinical, and imaging data using artificial intelligence. In the next slide, I will show you the step we have done since we have done so far. We have started from data harmonization, since the origin of the data are very different. So in order to manage this huge amount of data coming from a very different origin, a data harmonization first phase has been required. Next, the project is, we can resume the phase of the project in three main tasks regarding the multiple myeloma use case. The one dedicated to the federated learning, the second one to the data modeling and machine learning training algorithm for risk prediction, and the third one for radiomics. Regarding the federated learning, also known as collaborative learning, by definition is a machine learning technique that trains an algorithm via multiple independent sessions, and each one using its own dataset without sharing data. To this aim, we have shared a first dataset with our collaborator partners, and we have discussed the features of patients that would be useful for this part of the project, such as the therapy of the patient, so the age, and all the genomic abnormalities. Thanks to the selection of the feature, some synthetic data have been generated, and next have been validated. So in this first phase, we have used first cohort of patients, and now we are discussing this preliminary data, and we should proceed with a more large cohort of patients in order to validate the preliminary data. In the second task of the project, our aim is to model data and train machine learning algorithm in order to resume the very complex genomic heterogeneity that I described you before. As you can see from this image, these are some results that we obtained so far, where from the study of a large cohort of genomic abnormalities of multiple myeloma patients, we have been able to identify a subgroup of patients, as you can see from this image, for example, patients that owned this particular genomic alteration, the chromosome 1 amplification and the 13q deletion. And this particular subgroup of patients have a worse prognosis. So starting from the management of the genomic abnormalities, we correlate this information with clinical information through a machine learning algorithm. And the last task of multiple myeloma in the GenoMed4All project is dedicated to the radiomics that use the similar algorithm as the previous task, as I told you before, but it started from different origin data that are the PET scan images. So the algorithm have been trained with these images, and have been trained in order to know the specific image features that have been able to train the algorithm and learn it in order to prospectively recognize without any inclusion of the physician of the image in a prospective manner. So to wrap up this multiple myeloma use case for the GenoMed4All project, we have seen that multiple myeloma is very challenging since it is a very complex disease, but it still needs a cure, and therefore every research and every study in this sense are very useful. And there is a strong need to interconnect the clinics and biology in order to better predict the patient's risk. And a precise prediction requires this huge amount of data in order to be statistically significant and clinically meaningful. The artificial intelligence can help in data management, interconnection, and prediction. And to date, with our partners in the GenoMed4All project, we aimed at the integration of both the clinical, genomic, and imaging of a large cohort of newly diagnosed multiple myeloma patients in order to identify predictors of early relapse that can refine the definition of high-risk patients. In the future, these results will contribute to an improved design of clinical trials and a better patient management towards a more precise medicine. I would like to thank all the people involved in this study, and in particular the Multiple Myeloma Research Unit in Bologna, our partner in the GenoMed4All project, the Professor Castellani, Santiago Zas, and Piero Fariselli from the University of Turin, and all the patients involved in the studies, and all of you for your attention.
Thank you very much, Marina. So we have a little bit run of time, but I think we can at least address one question per group. So Diana, can you please share the questions? Thank you very much. So the first question is for MDS and sickle, for what I'm seeing. So a question about data. Since MDS and sickle cell disease are rare diseases, how do you handle missing or incorporate data when feeding the artificial intelligence? So Matteo, do you want to go first?
Yes.
And then Maria first?
Thank you so much. So very important question, because we know that when we are referring to rare diseases, the capability to collect comprehensive and high quality data is not so evident. So in our project, we implemented two solutions in order to face with this issue. The first one, as all the speakers mentioned in their presentation, is the strategic alliance with EuroBloodNet. That is a reference network that is really focused on the collection of clinical and genomic data with high quality. This is the first point. As a second point, we implemented also a strategy in terms of new AI technologies in order to be able to manage the point of missing data or incomplete information. That is the development of the so-called synthetic data. So this type of data are generated by artificial intelligence and are able to improve the availability of information, starting from even few real data, and provide to replicate patient without any missing information. So this technology, of course, is not a substitute for the need to collect high quality real data, but can help to accelerate research and clinical evidence for rare diseases, for instance, by providing the opportunity to create cohorts for validation of the tools and so on. So I think that in order to summarize my response, of course, we need high quality real data, but artificial intelligence can also help us to face with some issues associated with incomplete information by using the technology of synthetic data generation.
Thank you. Mario, want to go?
Yeah, I can just add the role of the registries, the standardization of the data that was already mentioned, but in this we are working a lot on the registries strategy. So really having a standardized clinical data, because as you have seen in the 3 use cases, the complexity is very high. And then even if we have lots of data, if it is not standardized and we all do not understand the same when we are collecting the data or labeling the patients, then at the end we don't have this quality. So I would emphasize this. And the second point, what I mentioned that we wanted, I don't know if it was really clear, but what I wanted is to do something that is based on reality. So for us, it doesn't make sense if we develop AI algorithms that then for these algorithms to work, we need some data that normally is not collected or not generated. Because at the end, then when we want to expand the solution to other clinical settings, then it won't be applicable, because it would be based on some type of data that normally is not generated for the patient. So really, we want also to have solutions that are based on reality and that can be then translated into the clinical settings. And this also reduces the missing data. So standardization for me, and through the registries and common procedures, and based on reality or what can be really be feasible in the disorders. Of course, incorporating advances on research, but based on reality.
Thank you. Okay, so if no more is to be added, I can move to the next question. Do you plan for the GenoMed4All project to include other hematological diseases in these studies? And will these models be available only to EuroBloodNet?
Maybe I can start with a short comment from my side, if you agree. So basically, the final aim and maybe the ambition of GenoMed4All is to create a technology that can be implemented within the EuroBloodNet network. So we mentioned that one of the aim of the project is to create a federated learning platform in order to facilitate sharing information, including clinical data, genomic data, images, and so on. So our goal or final goal is to be able to implement all these technologies in EuroBloodNet. That means that the network will be able, at the end of the project, to start new projects on other rare hematological and maybe ultra-rare hematological diseases in which patients are affected with unmet clinical needs and to address relevant clinical questions by using artificial intelligence.
Maybe the second part, if the models are available only to EuroBloodNet, this is something that we need to discuss, I think, in the consortium, know how to also have other members on board. So, but I think that the first point, as Matteo said, is to develop all this infrastructure as the main infrastructure for the ERN, EuroBloodNet. But of course, we would like to reach or to increase our outreach in a second phase. So, but we need to see how to onboard other members. It's not restricted. Actually, it's not restricted, but we need to see the legal mechanisms. And I don't know if Marina would like to add anything on any of the two, even for the first one, because probably missing data is also important.
Yes, of course. So for multiple myeloma, this project is very important, but with respect to what Matteo said and also Mar said, I don't have anything to add. I think that if it works for multiple myeloma, can work also for other hematological disease of the EuroBloodNet.
Maybe if I can add something, Maria Angela, that is also important that all these procedures, no, and all this infrastructure that we are developing, the point is that also in the future, in 10 years, if there is something new on the same disease, we could also have new models in the new disease relying on what has been built so far. So I think that is really the way to move forward. I don't know if I am clear, but it's not only what we are doing now, but we are developing the basis to really boost research on hematology through these new approaches in the future.
Clear. Thank you very much. Well, I would like to thank all of you for this webinar. So first of all, thanks to the speaker for having shared all the time and the expertise with us. And then also to the audience for being here with us today. So I hope to see all of you on the 4th of October. Thank you very much.